Good morning. My name is David Wright. I'm a professor of nursing at the University of Ottawa. I am one of the co-chairs of this seminar on nursing, together with Bessie Bitsas, who is seated here, and you'll meet a little bit later. The idea for this seminar was really to focus on the critical difference that nurses make in palliative care. And so we're going to have 3 sessions, starting with Heather Richardson, followed by Lacey White, and then we will have lunch, and then come back, and at 2 o'clock we have a session with Stephanie Avery, which we hope that you will return for. But right now, it's my absolute pleasure to introduce Heather Richardson. Heather Richardson currently works as the Director of Education, Research, and End-of-Life Policy at St. Christopher's Hospice. Previously, she worked as Joint Chief Executive, then CEO of St. Christopher's over a period of 8 years. Heather is a registered general and mental health nurse and has worked in hospice palliative care since 1988. Her PhD research concerned users' experiences of day hospice. She has done many other things, but I want you to have a chance to hear from her directly, but I will point out that she has received numerous awards related to her role in innovation in healthcare, including the International Palliative Nurse of the Year Award from the International Journal of Palliative Nursing. So it's really our pleasure, all the way from the UK, Heather Richardson, welcome.
Thank you so much, and I've been really looking forward to the opportunity for a conversation with people in the room, particularly nursing colleagues. So if you are a nurse, do you mind just putting up your hand? Great. I would love to talk to you today about how we advance our practice, how we develop our profession, how we protect what's most important in what we do in palliative care. And if you're, I don't want to say a non-nurse, but somebody other than a nurse, do you mind just putting up your hand as well? Thank you so much for coming, because actually we need you to be alongside us to critique what we're doing and to help us really perform well as part of a multidisciplinary team. I'm going to talk a little bit about what I think the future of palliative nursing can be. And I am going to take you on a journey to think about what the contemporary issues are in palliative care, how nursing really can have something to offer, and how we might really amplify that moving forward. Let me start with some greetings from St. Christopher's. As most of you will know, it was the home of Cicely Saunders. It was her petri dish, her laboratory for advancing practice, developing an evidence base, and then disseminating all that she'd learnt. And most recently, we've built a centre for the awareness and response to end of life. It's our opportunity to educate professionals and the public in end of life care. And we'd love to see any of you there if you'd like to come and learn with us. But let's begin the story that I'm going to tell with its ending. So if we were to advance nursing practice, if we were to develop our profession and be really confident in it, what would we do it for? Well, we would do it to maximise the very best of life for people for whom life is coming to an end. And I want to introduce Bridie. She's the mother of my friend and colleague Marie Cooper, who has been helping me in a lot of my thinking about the future of palliative nursing. She's the woman in the bed. She's holding a flute of champagne, and she is toasting her daughter Elaine, who's on the right-hand side, whose 60th birthday it is. And what I love about this is that she only died 3 days later. But she's in her own bed, and for me, it's an image in which she looks safe, she looks comfortable, she knows she has value, she is still connected to all of her family. And it's the kind of ending that I'd like for the people that are closest to me, It's the kind of ending I'd like for myself, and it's the kind of ending that I hope I give to people that are in my care. And what I want to argue is that it needs primarily a focus on people's identity and their well-being if that's going to happen. It's not a simple thing, and the only way, if you really want to focus on identity, you have to find and then protect the person. Now, this is not a new notion at all. Cicely Saunders spoke about it. We saw this quotation this morning. It's probably the best known of what she said, and it's often used, less enacted, I would say, but it's an aspiration of many. And it is difficult at the best of times, and I'm going to argue that it's even more difficult in today's context. One of the reasons that it is so difficult is that people die. The way people die in today's world really challenges their personhood, as does the way that care and care systems are constructed and the kind of societal values that we all hold. And I'm going to speak from a UK perspective, but I'd be very interested to hear if it's the same or different to your own experience. Dying in 2022 feels very different to me to the dying experiences that I witnessed at the start of my palliative care career in the late 80s and early 90s. At that time, I only looked after people with cancer. Median survival was often less than a year. People's trajectories were incredibly easy to predict. And if they didn't go as you predicted, it was usually good news. But today's world, the kind of patients that I see at St. Christopher's, more than half of our patients are dying with frailty. That is a trajectory and a condition that is clinically very uncertain. It's characterised by multiple needs and problems, and the individuals that we look after are often living in late old age. They're isolated, not just socially, but practically as well. If you add into that the way that care systems, health and social care systems are constructed, you start to see the complexity of trying to hold on to people's personhood. This is that people's experience is something of a conveyor belt. Very often they haven't actually asked to join the conveyor belt. They can't control its speed. They don't know where it's going. They're introduced to services that are meeting needs they didn't even know that they had. And very often, they have no idea how one part links to another, except that they are consistently asked to tell their story again, again, and again. It's a system as well which is pretty risk averse. So when people want to get off the conveyor belt, they're not allowed to, because actually you've got to go from the top to the bottom, and you've got to do it the way that the algorithm suggests. Add in that, even if you as a health professional, and lots of us here today, we are part of that system, and we don't want our patients to be on a conveyor belt. We don't believe in that, but it's extremely hard to help people come off it. And that's partly not just about the power of the systems, it's about the power of our society in which we're trying to work. So even if we as professionals decide that actually we would like to work stronger in partnership with people who need our care, their families and carers, we want to help them make a decision about whether they ever want to get on that conveyor belt. Societal values are often working against us. If you haven't read this book, I'd recommend it. It's written by an American, but based in London. It's a story of a GP and his wife, and they decide in their 60s that they are going to end their own lives when they're 80, because they so dread late old age. And they feel that there will be nothing for them. They're so focused on maintaining control. They fear suffering. They are frightened of a loss of dignity when they can no longer look after themselves. They don't believe that their children will look after them or protect their best interests. They have both been carers themselves, and they hated it. and they are really concerned that the risk-averse nature of healthcare will deny them any opportunity to live creatively. If you add into that people's fears around the Ukraine, the global economy, politics, particularly in the UK, you can start to see why quality of life at end of life is so much harder to achieve. This is my colleague Alison. She died just a few weeks ago. She was the finance manager at St Christopher's, and I went to see her at her request in a large ward in an oncology centre in London. And she had had a late diagnosis of an ovarian carcinoma, and when I met her, this woman who normally would have had agency, power, a strong sense of control in her life, was very frightened. She had no idea what was happening to her. She was very worried about her children, who she hadn't seen for a couple of weeks. She wasn't entirely sure whether she was under a surgeon, an oncologist, or an endocrinologist. And she was desperate to remain in some control as a mother, as a daughter, as a wife, despite her daily decreasing ability and function. And the sadness of this is that the only way that I could help her regain her personhood was to move her out of the hospital setting into the hospice. And I don't tell that story because all hospice is great. It's because she was known in that context. People could relate to her once again as a friend, as a colleague, as somebody who had young children. And in the 7 days that she had between coming to the hospice and dying, she was able to do much of the stuff that was really central to her anxiety. So if you have that kind of contemporary suffering, that predicament, and Alison was not alone, what do you do? And I'm going to suggest that you call for a nurse. And I want you to look at this photograph just very briefly and think about what you see. It's taken from our oral history at St Christopher's. It's probably a 1970s photograph. And there is so much that I love in this picture, not least the nurse who would have been breaking all the rules, sitting on the bed in an apron, in close proximity with the person that she is having that all-important conversation with. Siobhan Horton, who is a great thinker, she's a senior nurse from the UK, sadly totally underpublished, but she's done a lot of thinking about the artistry of nursing. And if she was to look at that photograph, she would say that what was happening there that was so powerful was the personhood of the nurse meeting the personhood of the patient. And a lot of people would say at St Christopher's, if I talked to them about that, they'd say, yes, that was easy to do then. In 1975, we had so much time. There were so few rules and regulations. This is a photograph of contemporary nurses working with street homeless people in London. And I say to you that you can see the same person-to-person connection here. These are nurses who've come out of the safety of their institution. They're not hiding behind security, structures, processes. They have come and they've met this person in his context to understand his world, to protect his personhood, and to make plans with him about his future healthcare. So it is possible, even with the challenges that I've described above. If you can bring your artistry to care, if people can feel held as people, then there is fantastic impact for patients. And I've got a couple of quotes here that I just took from letters of thanks, cards that we received in St Christopher's in the last year. And they tell me that when we do our care well, people's identity, well-being and value is protected. People feel safe, comfortable, connected, involved. And what they can do then is to attend to what is most important to them. And that was central to Alison's suffering earlier when she was in a hospital where she just didn't know what was going on. Siobhan goes on to say that the fundamental value of the artistry of nursing is not only for the end of life, it's not only for those moments of suffering and terror, but it's also around helping people to live well. And remember Bridie at the beginning with her glass of champagne and her family. She is not in a place of suffering and terror. She's in a place of fullness and richness of life. But it isn't there, it isn't because she's lucky. It's because everything around her is focused on her well-being and her identity. And here are two more quotations of patients who have fed back to St. Christopher's and families about the care that they received. Again, when we get it right, we really get it right. And I particularly love the quotation on the right. You gave me back confidence to get out and start living again. That is artistry of nursing at its best. So, what does an artist do? Well, they are creative. They are looking, feeling, appreciating something, and then they are translating it into what is most important. And I want to persuade you that actually artistry is only possible when we as nurses adopt an Asclepian approach to care. It is about authentic presence. It's about authentic relationships, engaged and concentrated attention. And it's about really actively engaging in personal growth for professional purposes. Siobhan writes very powerfully on this. She isn't suggesting for a moment that you shouldn't also attend to the science of care. She would say that it is important, but very often in today's world, we're more concerned about the science of what we're doing at the cost of the artistry. This is a lovely photograph of Cicely Saunders and David Tasmer. It's taken from a recent play that was done in Edinburgh. And Cicely was took a lot of effort to think about the relationship between the art and the science of care. And apparently David Tasmer, a 40-year-old, somebody in her care very early in her career, said to her, I want only what's in your heart, in your mind. And when she reflects on that and writes about it in years much further on, she says that David Tasmer's request should be seen as a plea for all the science and learning of the mind, coupled with the vulnerability of one person with another. We're back to personhood and personhood. It looked to the bridge between love and science. When we get it right, when the artistry of care really comes to the fore, then I want to suggest that for us as nurses, we can have hugely positive impact in our practice, but we can also enjoy sustained professional life. I'm going to come back to therapeutic leverage. I think that's really important, but I want to speak briefly about the other two elements as well. There's good research done by one of the nurses at St. Christopher's. It's published, Maria Apparaccio, who looked at the place of gratitude in sustaining nursing in their practice. And part of the artistry of nursing is engaging with people, receiving feedback, knowing that people are grateful for what they get. And most of us come into our profession, and this is not only for nursing, it's true for medicine as well, because we're driven by vocation. And so when you do the right thing, however hard, when you make a difference, however challenging, that's what sustains you and gets you back to work the next day, the next week, the next month, and next year. Gardner, who was a mental health nurse in Australia, this is an old paper, 2010, I think the references are at the end of my presentation. He did a lot of work around therapeutic friendliness and the development of therapeutic leverage. And I think some of the toughest clinical events that I've participated in as a nurse have either been assisted or thwarted by the presence or the lack of presence of therapeutic connection. He has an idea that there are different levels of engagement. I recently witnessed somebody fall off their bike on the way to work, and I saw therapeutic connection happen between a paramed and somebody who was injured on the road in just a few seconds or moments. So it is not something that takes a lot of time, but it takes intent. It is about being purposeful in that connection. So how is that artistry both protected and enhanced? And I'm going to suggest that we need to take personal responsibility for our development. If we want to offer relational care, we want to connect individual to individual, then these are some of the areas of development that we need to invest in. But I'm going to suggest as well that organisational effort, organisational investment in us is really important. And unless you have both of those, nurses just simply can't keep going. And for the non-nurses in the room, please help us with the organisational effort. We talk very much about needing access to other professional expertise, and I think we do. I have worked as a lone nurse in a hospital team in the late 1980s. It was very lonely professionally, but I was also much less impactful than when I was joined by a doctor and a social worker. The other thing that I want to suggest is that peer support, learning, and a desire of change could absolutely be key to protecting and enhancing the artistry. And that's the next bit of this presentation. What could we do together? I think peer engagement on the issue could be our biggest opportunity. It would be our chance to have a louder voice, greater clarity about our unique value, and we could enjoy together sustained advocacy for representation and investment in our profession. It sounds so simple, but I know that actually it's a huge challenge in reality. And I'm shocked at the passivity of our profession. I'm shocked at the lack of belief that we have about opportunities for change. I'm sad about the lack of connection that we have across the globe as nurses, and some of the work that I have started to do with David, Mahogany and others is about trying to build a community of nurses that can push for change. And I'd love you to be part of that journey. I'd love to be part of your journey. It could be something that we do that is shared. And I think most of us are preoccupied with daily challenges at the cost of strategic change. And what is happening as a consequence is that everything's getting eroded in terms of the sort of longer term drive for a different world. Our biggest problem, I would suggest, is a lack of shared vocabulary or rhetoric about our value. Do read this, and I want you just to think about how contemporary is this? We all have a private image of nursing practice. In turn, this private image influences our interpretation of data, our decisions and our actions. But can a discipline continue to develop when its members hold so many differing private images? That's contemporary, isn't it? Do you know when that was written? 1975. That's shocking. And nurses today, I've been privileged to be part of a community of nurses from around the world, and we did a bit of work about what I would say in Montreal today. And people spoke about needing a united voice, being clear about what difference nurses make, the way we can change a patient's outcomes. I'm sure playing this down is an element of our terrible pay and our conditions. So I'm going to propose to you a solution. It may not be right, but I'd love to hear a bit more about what you think. I think we need a model of nursing that we can own and develop as a professional group. It needs to be contemporary. It must be centred on the needs and the wishes, the aspirations of the people that we want to look after. It must clarify what we do uniquely well, but also how we fit with the wider MDT. And it needs to confirm the inputs required on the part of nurses, our organisations and the multidisciplinary team in order for us to get care right. I'm going to argue with you today that it must reflect professional experience as well as research evidence. Everybody who's in this conference is pretty sophisticated thinkers as nurses, as researchers, as experts. But I actually want a model of nursing that will fit my colleagues who work in care homes in the UK. People who don't sit in the specialism of palliative care, but are doing really high quality end-of-life care as part of their everyday practice. And I want to create a model with you that reflects the artistry of care alongside its science. And I'm going to say to you that I think we start with practice and then we generate the theory behind it. And both Florence Nightingale and Patricia Benner would support that. I love Benner's work, that idea about practice-based evidence rather than evidence-based practice. You need both. It's the tension that could take us to the next step. So I want to introduce the lantern model, something that Marie and I have developed. We did it in lockdown. I desperately needed to do something creative. We started with patient and family feedback, and then we looked at practice on the wards that we worked on in the community, and we looked then at the evidence and the degree to which the evidence matched experience. And I want to thank people like the people in this room who really helped us with our thinking about that. We based it on a well-validated model of person-centred care developed by Brendan McCormack and his colleague, please tell me his colleague, Tanya McCants. And we have tested it around the world with practitioners. And for most people, there is a very high resonance with their practice. So I'm going to show you an animation now that brings the lantern model to life. It is not something that I want you, I'm expecting everybody to take on lock, stock and barrel, but could it be the beginning of a conversation?
As nurses, our skills and experience guide us in caring for someone at the end of their life. We know that death can feel uncertain or frightening, and that those in our care seek comfort and reassurance, but also wish to feel like themselves in the time that they have. We know the power of listening, of connection, and of caring, person to person. Our work takes compassion, generosity, confidence, and courage, although we're often too modest to say so. But to be at our best, there are things we need too. Space to care, support from our professional peers, and ongoing investment as acknowledgement that what we do is invaluable. As nurses, we carry all this knowledge of care in our minds and our hearts. We are artists as well as scientists in our efforts. But how do we explain our experience and our needs to others? How do we share the wisdom? Introducing the lantern model, capturing the best experience of nursing at the end of life. The model starts with the outcomes that are most wanted and needed by the person facing the end of life. We respond through our offer of care and support, connection, help with planning, coaching and caring, and being present as someone's condition deteriorates. Add in support from the multidisciplinary team and the conditions in which nursing thrives. And finally, the personal attributes which make the best nurses. Our model creates a flower, the lantern flower. It survives in the most challenging environments to share its beauty, just like nursing. The Lantern Model. A unified way of thinking and talking about the work we do as nurses.
Great. That was its premiere, by the way. It only came into my inbox yesterday morning, so I was quite relieved to see it. I don't have much time to tell you about it, but you're welcome to contact me. I can send you a copy of it, and very happy to talk about it further. One of the things that the animation doesn't capture sufficiently, in my view, is the key tenets that shape and guide the care provided. They're the root of the plant, and they are about being inclusive, and they're about finding the person in the patient always. One of the things that's important to say is it is multi-layered, but it is the interconnectivity of the different elements that's key, and it is what helps to show everybody what's unique about the nursing part of it. How could it help our profession and our impact moving forward? It could be the start of conversation between nurses around the world. It could be the beginnings of a shared language. It could be a reawakened appreciation of our character, a collective confidence about what we do well and differently from everybody else. It could be confirmation of the support that we require, both as individuals and a profession. And I don't want that to remain as it is. I would love anybody who's interested to take it and contextualise it. It should be the start of a conversation. If we did it well, and not necessarily just with the Lantern, but if we were to start to be a global community of nursing, I think we could maximise impact on the part of nurses. If we were confident about what we did and our professional colleagues knew best how to support us, then we would deliver high quality care, people would die as they lived. And I think you would get an outcome which was that death and related care was better understood and shaped how people use services in the future. But it's not just about our impact, it's about outcomes of care. And I think if we were to rally and really work together, we could achieve a stronger experience of dignity and respect. People could be confident of what's happening to them. They could retain their personhood. And the people left behind could integrate loss into future life and experiences. And that's the virtual circle that we need to get to. And then there is societal benefit. And I think this is important. Actually, if we were stronger, there might be earlier engagement in end of life, there might be greater confidence in services, there might be more interest to share risk and opportunity. And for the families, for the carers, for neighbours, for friends, a desire to participate and improve care for others. So I'm going to finish now, and hopefully there are a few minutes for conversation. But I would love to hear from you. Do we want a different future? As individuals, as teams, as a profession? Could we work together across systems and the world to capture the richness of nursing at the end of life and to lobby for greater attention? Could that model have value? Doesn't matter if it doesn't. And if it does, where does it require modification? Where does it need further elucidation and development to make it our model for contemporary conversations? Thank you very much.
Heather, thank you so much for that. You offered us so much, and one of the things that has really struck with me since you presented it and throughout the talk is this picture that you showed. You love this picture of this nurse kind of crouching down and breaking the rule. And I've always kind of thought that that's something that's so remarkable about palliative care, is that we kind of we'll follow rules that make sense, but if rules don't make sense, we'll change the rule to kind of really suit the personhood of the patient. And now I feel like you've offered us kind of a comprehensive model to kind of really, what are all of the processes by which we can make that happen, right? So we do have time for questions, conversation. We are also live streaming, so for participants who are joining online, you can type a question and Bessie will present it to Heather. But we have some microphones, so if people would like to ask a question, please go ahead. Yes.
It's more of a comment.
Yeah. Could I ask you to go to the mic, though, just so that people online will hear you? But I can also roam with the mic.
My name is Esther. I'm a palliative care nurse trained in Canada, but my most recent experience is in Senegal, West Africa. And I've been following some nurses in a clinic in a home care agency there. And so I haven't figured a lot of things out yet because the context is so extremely different from Canada. But I was just wanted to share about what he was saying, because I think what's happening, and this is just my perspective, so I don't want to talk as if I'm an expert because I'm not, but there is a real dissonance between our Western way of education and the way people in other cultures have learned in the past. And this Western way of medicine has been elevated. So now it's really causing, I don't know what you call, between. So I have to laugh because the clinic that I worked in, the staffing was 3-to-1, 3 staff for 1 patient. Nurses were always in the room, joking around with people, lying in their beds, sitting in their wheelchairs. There's, when you talk about professional stuff, I never saw hand washing. I never saw rubber gloves being used for anything more than a tourniquet. But there was this beautiful connection that they had that I felt in myself as well challenged, because it was hard for me to be there and not get fixated on, oh my goodness, you're not wearing gloves when you're starting an IV, you're recapping a needle, you're sitting on that person's bed, it's COVID, you're all that stuff. But the beauty, and I just felt because I spent 6 months with this one clinic, they all eat together at lunchtime, and no one, they didn't get paid very much, but no one complained about their job.
Yeah.
It was really about the people, but then there was so much of this other stuff that I had from my Western education where I was like, oh my goodness. So I'm actually going back next week, and I'm going to be going to a nursing school and doing a 3-hour about palliative care, but I'm very curious just to maybe connect with you after.
Good luck.
About
yes,
that too.
And we'd love to talk to you. We have a very a really inspiring global program in palliative care, and I would agree with you. I think our biggest challenge in high income countries is the litigious nature of health, the overregulated area, the overregulated context in which we work. And people are exhausted. That's a kind of rhetoric that's happening in the UK post-pandemic, and I have actually huge sympathy with it. But what I see is highly transactional care. That's what I'm most fearful for in terms of our future and the future of good end-of-life care. And I see it even in my colleagues, that it's very easy to switch from relational care, which is at the heart of artistry. It's at the heart of that approach that Siobhan describes. And if we allow it to become transactional, then there really is no difference to, actually it's worse than having robots. At least robots are consistent.
Hi, my name is Paulette. I'm a home consult nurse in the palliative world in a very rural site. I work independently with a physician only 1 day a week, so I have pretty autonomous practice. But this morning's session and your session I find really go together. And what I appreciated is when I walk into a hospital to check on my patients, I see a group of nurses that are extremely tired.
Yeah.
And then the care that gets trickled down from there is a direct result of that fatigue and tiredness. Yeah. I think we talk about patient-centered care, we talk about family-centered care, but we forget about team-centered care.
Yeah.
And the thing that resonates with me the most is that we're forgetting how to work together, how to connect, have those connections. So I thank you for your work. I'm going to borrow some of your work when I present hopefully soon at a conference in November. And I really would love to hear your thought on how we can improve team-centered care. You know, I think we've talked about patient-centered care, family-centered care. We have all these models to pull on. We have the caring sciences, all the caring theorists that help us with the C's of caring. But where we fail is taking care of each other. How do we start the dialogue of saying, you know what, you look tired today, what can we do to make this better today?
Yep, I think the model could genuinely help, because I think the organisational requirements for really supporting nursing, when we talk about space for care, that's about time, but it's also about physical space. It's about time for reflection, investment in people's personal and professional development, and so on. That is absolutely crucial. And I think that when we were creating the Lantern model, we spent a lot of time, we were very exercised about the degree to which we should co-locate nursing processes with those of the wider MDT. And I'm so glad that they sit right in the centre together, because actually nursing processes without access to that wider multidisciplinary offer will never maximise the impact that we can have. There's an alchemy. And that slide that I glossed over around the fact that actually it's the interconnection between nursing processes, the work of the multidisciplinary team, the sort of tenets that absolutely ensure an inclusivity and a person-centred approach. It's that which we've got to work on. If we just look at nursing alone, you just keep finessing only one ingredient in the cake. Shouldn't mix my metaphors.
Hi. Oh,
Hello.
Let's see, I'm going to have to raise this up a little, and I'm nervous. So I'm Eric Fromey. I'm a palliative care physician with the Serious Illness Care Program at Ariadne Labs in Boston. And so our thing is actually trying to get non-palliative care people to do some palliative care things. Mm-hmm. So in our case, it's serious illness communication. And we believe really strongly that that is a team sport and that everybody on the team has a role. Mm-hmm. However, when we have tried to venture into, how can we involve nurses in serious illness communication, we've gotten a lot of pushback, mostly from nurses who are concerned that, hey, if the rest of the team is not on board in this, I don't want to get in trouble for, starting these conversations that then, I get scolded for doing something that's outside my scope of practice. And our impression is that when that happens, it's generally because the physician on the team misunderstands what a serious illness conversation is. Like, it's a conversation about your goals and values and like what's most important to you. Things that are clearly within nursing scope of practice. And when you're trying to reach everywhere, this is a barrier that we keep encountering. So I'm wondering if you have any advice or any suggestions about how we might reframe for these organizations, health systems, that we're trying to, I don't want to say expand the role, that's ridiculous. Nurses are already having these conversations, they're just not telling anybody about it.
Exactly.
Yeah.
That's a great question. I think there are two issues, two real opportunities in response. The first is that our organisations need to be so much more risk confident. Nurses at St Christopher's are doing, and I'm not actually suggesting that this is unique to St Christopher's. I know it will be true for everybody in this room and much wider. Nurses are taking risks all the time. They're working outside their role. If they are confident and connected to the person, they are doing stuff all the time that falls outside the process, the formal processes, but they're doing it under the wire. And one of the things that we did at St Christopher's when I was chief exec there was to try and persuade people to do it above board, because then we could cover their back. We could negotiate when it was too risky or just risky enough and we were going to support them. So that's, I think we because of the litigious, highly regulated thing, we're getting more and more frightened, and we shut down opportunities for people to be creative, to be courageous in their practice. And it does happen, it just happens under the wire, and everybody's vulnerable. But the second thing is, and this is directed to nurses in this room, we are allowing huge erosion of our role. And when we allow that role to be eroded, it's not just that we lose an important function, but actually the satisfaction that comes from our job of being artists and responding as person to somebody's need is reduced. When you have to keep saying, thank you, I hear that, but I'm now going to go and get my medical colleague to do this. Thank you, I hear that, but I'm going to go and get somebody to help change you. Thank you, I hear you need that, but listen, I'm going to go and get a physiotherapist. We do not act in the way that has most given me pleasure and huge professional pride in my historical career. So we must stop giving it away. So I'm coming to work in Boston and I'll do any number of those conversations because I think that's part of the artistry of nursing. It's part of your artistry as a doctor as well. And I think that's what I meant by everything becoming so niche.
Yeah.
And I see amazing practice, but once it becomes part of an algorithm or a kind of allocated responsibility, people feel they can't do it anymore. That's a tragedy.
Amen.
Thank you.